اونلاين بس يلا معلش.
يلا خير ان شاء
كانت
الله.
شويه.
ماشي اتفضل
كل
بقى
سنه وانتم
شارك.
طيبين.
انت طيب.
كل سنه وحضراتكم طيبين جميعا طبعا. من غير ما نذكر اسماء ونسيب اسماء اساتذتي وزمايلي كلهم منورين. شكرا جزيلا على الدعوه الكريمه، وكان نفسي اكون معاكم شخصي، يعني مش عبر الاثير زي ما بيقولوا.
تمام تمام، انت منورنا يا
طيب
دكتور قصبي. لو هنبدا بقى حضرتك تشرفنا بالمحاضره بتاعتك.
طيب انتوا كده شايفين البرزنتيشن؟
تمام.
هو في لاج شويه متهيألي، انا بشوف الصوره على ما
في لاج بس الدنيا واصله يعني مفيش مشاكل.
طيب مساء الخير جميعا. Good evening ladies and gentlemen. My presentation is about staged approach for endovascular repair of thoracoabdominal aneurysms, mainly talking about type 4 thoracoabdominals. So we all know that paraplegia is one of the most devastating complications of thoracoabdominal aortic aneurysm repairs, either open or endovascular. Problem with endovascular repair, it's lack of ability to keep perfusion to the intercostals and the lumbar arteries that is inherited with the endovascular repair. So in terms of combating this complication with endovascular repair, there are two approaches. One of them is to divide the coverage of a long segment of the aorta over two-staged procedures. And the other one is to create an intended endoleak, type 2 endoleak, to keep perfusion of the lumbars and the intercostals for a while, and then re-occluding this branch of the graft and treat that intentional endoleak. The other way, of course, is incorporating a custom-made branch or fenestration for one of the big lumbars or the intercostals, or maybe the Adam coax artery if it's identifiable on the pre-op CT, of course. Can you hear me, or should I keep going? I'm not getting any feedback, so I'm not sure if...
لا قصبي انت مسموع كويس يا جميل. كمل يا باشا. احنا دلوقتي قدامنا على الشاشه البيبر بتاعت جورنال فاسكولار سيرجري ستيجد اندوفاسكولار ريبير.
Yes, so this is a publication by one of my colleagues when he had his fellowship up in Cleveland Clinic, and this is to compare the results of staged EVARs as non-staged one, and actually divided staged ones into intentional and non-intentional staging of endovascular repair of thoracoabdominal aneurysms in terms of the incidence and severity of paraplegia or spine ischemia. So if we could look at the groups, we could see that there's nearly 30 patients in each group. So single stage, two stage intentionally or unintentional repair, where you had to do one stage and then do the second one, or you might have treated one aneurysm and then came back to treat the other aneurysm with the extension of the previous stent. And as you could see from this slide, that the incidence of spinal cord ischemia was the highest on the single stage repair as compared to the other two, and be the least on the planned two-staged procedure. And that was significant in terms of both incidence and severity for the three groups. In terms of all complications, again, spinal cord ischemia was higher in the single stage procedure, reaching up to maybe 37% as compared to only 11% on the planned two-stage procedure. And the 30-day mortality was also higher on the single stage procedure as compared to the other ones, as well as most of the other complications. Overall survivals were also better on the planned two-stage procedure as compared to the other two groups. So on that general consensus, the strategy for treating these aneurysms was also taken into a staged approach in the center that I was working in. And this is a case that I've treated a couple of years ago, who was a 66 years old gentleman. He had a very complex medical history with history of atrial fibrillation, being on anticoagulant. He was also, of course, hypertensive, but he had dilated cardiomyopathy and congestive heart failure with ejection fraction of only 20%, with left ventricular dilatation and severe tricuspid regurg. And he also had a history of bilateral inguinal hernia repair to complicate his growing cut down a little bit, and history of peptic ulcer disease with perforation and surgical repair in the past to render his abdomen more adhesive and more hostile. And on top of everything, he had a crush injury to his left arm in a previous car accident with contracture scar after a skin graft of this crushed limb. Now, the circulation was fine on that limb, but because of the scarring and because of the contracture and the deformity, access through that limb would have been also not easy. So this is his pre-op CT scan with a type 4 thoracoabdominal aneurysm that measured around 6.5 centimeters on his on his first presentation. And the plan was to work him up and see if he's okay to go into an endovascular procedure in terms of his cardiac comorbidity and all of that. And he was being optimized, seen by the cardiologist and all of that. And unfortunately, he, well, this is his cardiac MRI scan, and it showed what I've explained to you about his left ventricular dilatation. It's just a nice image to show there. But anyway, he presented while he'd been optimized with back pain and vague abdominal pain, and we thought that he ruptured, and we repeated the CT, and we found that the aneurysm has grown in size, maybe half a centimeter to a centimeter in less than 6 months. So we decided that we have to do something. Unfortunately, this guy is going to probably rupture, and we won't be able to save him, even with his high risk of mortality, and he understood that risk. So the plan was to go with 2 branches, 2 fenestration. I don't know if you've noticed from the CT, we can go back to that, but he had a separate origin for the hepatic artery and one small origin for a separate splenic artery coming directly from the aorta, and then the SMA and the 2 renals. So the plan was to give a branch for the hepatic artery and ignore the very small splenic artery, which would have been thrombosed anyway, and a bigger branch for the celiac, and then the 2 fenestration for the renals. And we went on and did the first stage, which was the EVAR, and that went uneventful. And everything went very well, with the plan to leave him for a couple of weeks, maybe 2 to 4 weeks before we do the second stage, knowing that this will be a little bit of a rush, but again, because of his symptoms. And again, he presents with back pain, and nothing to explain his back pain from the spine or the muscular side. The aneurysm, again, doesn't look like it has ruptured or anything, but that's the only reason why we've repeated the CT in between the 2 stages, just because he came back with symptoms again. And again, we were worried about this rupture. So we went on and did the second stage, which is the bifurcated fenestrated graft, custom made, of course, as I showed you. And this is the approach from both groins. And you can see the 2 renal stents with good perfusion of the renal arteries. We haven't done the SMA or the celiac stenting yet. You can see the empty branches there. And a little bit of a nice surprise during the procedure, his spinal drain becomes bloody. And the anesthetist is not happy. And he says that we'll have to either finish or do the quickest that we can do at the moment and get on with the procedure, because he's not happy with the amount of bleeding coming into the spinal drain. He's not happy about his heart. So we're rushing to go and having an access through his arm. And we've managed to, well, this is me putting the wire into his SMA, cannulated the SMA, went very easy, very quick, to be honest with you, unexpectedly, and stented the SMA, and decided to leave the one for the hepatic artery for a later stage, if even, to do anything with that. So this is his follow-up CT scan after the procedure. Very good recovery, but as expected, we would have seen some flow into the sac because we've left the branch for the hepatic artery unstented, and this is what was expected. This is what we've seen, and we've brought him for a third procedure, and that's a very frustrating moment when I'm there with the wire trying everything to go into that branch and nothing is working. And I was pretty sure that I was inside the branch, inside the graft, but not able to get out at all. And I think I've tried everything. My colleagues also tried, and we couldn't stent that. So I did an angiogram, and surprisingly, there is no flow coming out from that branch in the grafts. And what we're seeing is we thought is a type 2 endoleak, not a type 3 intentional one. So it's coming from backfilling of the SMA, from the splenic or the hepatic that kept patent, but not from the graft. So it looks like either the gate was crushed, which doesn't look like it on this one, or thrombosed. So we've decided to get out and do a follow-up CT scan in a couple of months' time. And as we thought, the aneurysm started to shrink with a smaller, well, it didn't shrink, but the endoleak, got a little bit better. So the decision was that this is probably just a type 2 endoleak with a stable sac at the moment. So the patient was kept under follow-up, and his CT actually showed shrinkage of that sac over time. So we never did anything more than that for the hepatic artery. So in conclusion, we think that taking a staged approach, dividing the procedure over 2 or even sometimes 3 episodes is safer for patients, especially if they have multiple comorbidities and of a very high risk of mortality. For example, the patient that we've seen in this presentation. Thank you very much, and I leave you with a lovely picture of Waterford Castle, where I work and I live now. And I invite you all to visit me at some stage. There is a very lovely restaurant in the castle that I would promise to take you to dinner there, but not promise to pay. I might get you to pay yourself. It's a bit expensive. Thank you very much.